So our goal today is to talk about treatment after prostate cancer treatments, basically taking care of problems with erections and urinary leakage as a result of prostate cancer treatment. So if you ask yourself the question, how does prostate cancer treatment impact men's lives, is that the most common long-lasting side effect of prostate removal, so surgery, radiation, prostate freezing or cryotherapy, hormone ablation, is erectile dysfunction. Okay, so super common. I'll tell you more stats on that later. Another unintended consequence of the treatment for prostate cancer is urinary leakage. There's a couple different types, which are some of our other speakers will get into later, but typically leaking when you cough or sneeze, called stress incontinence, is something that happens after surgery. The penis, unfortunately, sometimes shrinks and sometimes curves as a result of the surgery. And then, all in all, this impacts not only how men feel about themselves, their self-confidence, their relationships, and their intimacy with their partners. So our goal here at Mayo Men's Health is to be able to restore these things that you didn't ask to get, but were a byproduct of the treatment that you needed to address your prostate cancer. So a little review of anatomy. There's a picture of somebody from the side. And you can see here that here's the bladder. That's where the urine gets stored. Here's the prostate, about the size of a walnut. And through the middle of the prostate is where the urine flows, and then out the urethra, out the penis. Prostate does not do that much that's good. It keeps the urologists in business. It leads to talks like this. But it only has one primary role, and that's to help some of this byproducts of sperm or semen to help the sperm survive. But it really, other than that, doesn't have much of a role. And interestingly, the nerves that control erections run next to the side of the prostate, and the valve that helps control whether or not you can stop or start your stream and keeps you from leaking when you cough or sneeze is right in here. So here's a picture out of a textbook that a urology resident would look at prior to surgery. And this is actually describing the prostate surgery. So in this picture here, this is kind of from the side. Here's the bladder on the side, and here's the prostate that's partially being taken out. And here's the stump of the urethra. Eventually, the prostate gets taken out, put in a bucket, and then the urethra is connected to the bladder here with a couple stitches, so that space the prostate used to occupy gets brought together. A lot of patients ask me, Doc, does my penis get shorter by virtue of the fact that that space is gone? No, it does not. The bladder and the urethra is stretchy, so they can come meet each other. But the penis, unfortunately, does get shorter because it's a use it or lose it type organ. If you don't use your penis often, then it will get scarred, and the normal soft, stretchy tissue of the penis becomes hardened, and then you will lose length because it's less elastic. So here is a study out of Denmark, which I briefly wanted to touch on, out of 2016, and the Danes are very good surgeons. And actually, this is written by a friend of mine, Michael Fode, from Denmark. And so he did a study where he looked at 210 patients who were sexually active and had good erections 1 year after they had their surgery. Okay, so everybody was good going into the surgery. And then exactly 1 year after they finished the procedure, they said, are your erections as good as they were before we did anything to you? And of course, only 7% said yes. Okay, so that means that 93% of men are worse or much worse a year after the surgery has taken place. And most people think that a year is about as long as it takes to get back to as good as you're going to get. Okay? And of those men, of the 93% of men who didn't get better, only about 33%, 1/3, had a successful erection using pills, shots, or vacuum erection device. So the bottom line from this particular series from Denmark was that men who had prostatectomy, about 2/3 of them were going to need surgery to fix their erections down the road. Now, this is one series in Denmark, and the Mayo results may be better, they may be similar, but I show you this slide to tell you that it is not uncommon to have this problem, and it is a common collateral damage from taking care of the prostate. And again, surgery, radiation, cryotherapy, androgen ablation, it's hormones, they all cause negative consequences. So there's non-surgical treatment options, which I won't touch on too much, but there's essentially three. There's pills, and you can't watch TV without seeing commercials with tire swings and bathtubs, etc. And so most of the time, if you had prostate surgery, we'll give men pills like these for a while to help recover, but long-term, they typically wouldn't work. Then there's a vacuum erection device, which you can see in movies like Austin Powers, etc. And this is a solution that works for some men, but not a great long-term solution. And then finally, shots of the penis. So actually, guys will take a small needle and inject it into the side to get good erections. And about 40% of men in which that works will use that as a long-term solution. So certainly something that we can offer here, but sometimes the damage from the prostatectomy is so bad that the only option is surgical. And so here's a picture of some surgical videos, and essentially you have to think of the penis like a bike tire, all right? And what's supposed to happen during erections is blood's supposed to flow into the penis, and that's supposed to be air going into the bike tire. And so in order for that bike tire to if it's flat, in order for it to get hard, you have to pump air in, and then the air has to be trapped effectively in there. What happens when you have problems after prostate surgery is that, number one, the airflow in, or the blood flow in this case, is compromised because the blood vessels aren't as good after surgery. And then number two, and more commonly, is that even if blood flows into the area, it can't be trapped there effectively, kind of like having a leaky bike tire. So if you've got a tire with holes in it, you try to pump it up, it'll never get hard, right, because the air will just leak out. Same thing happens with the penis, and that's called a venous leak. So these are some pictures of what the device looks like, but what I want to show you is a brief animation at what this device actually looks like in a computer cartoon here. So this is a website which is great. It's Sex Health Matters, and you just type in sexhealthmatters.org, and it has tons of information about anything having to do with sex or urination, these kind of things. It's a website that I'm actually in charge of to make sure it's doing okay. And if you go to the resources page and do a patient toolkit, which I'm currently on, you can watch a bunch of different videos. I'm going to show you one brief video here, which is 1 minute and 12 seconds long, but I'm going to pause it intermittently. So there are a couple different devices on the market, but they're very similar. So here's a normal guy without an implant, and all of a sudden he's just had surgery and the implant has been placed in there. So I'm going to pause the procedure, and you can see here that this device in place is composed of 3 different components. I will unpause the video and let it spin a little bit. So the 3 components are the reservoir, cylinders, and pump. So you can see here that this is a closed system hidden completely inside this patient's body. If this were an actual person standing in front of you, you would have no idea they had an implant in. So completely locker room proof. And so what happens is when this device wants to be utilized, fluid goes from this holding tank right here into the cylinders of the penis. And so this guy has decided, okay, it's time to have an erection, so he squeezes this pump here, and fluid goes from this holding tank, this reservoir, into the penis. Now, if you don't let that fluid out there, the erection is going to stay there. So that could be 8 hours later, it could be next week. It's basically up to you. It's not like a normal erection. It's not one of those things where you have to, call the doctor because it's been 4 hours. So yeah, you can leave it up if you want, but if you have expensive vases at home, Ming vases, it's not advisable, that kind of thing. So then when you're done, whenever that may be, whether that's 15 minutes later or an hour or whenever it is, you decide, okay, I'm done, I'm tired, I want to go to bed. So you hit the deflate button, and then you squeeze the penis, and the normal saline or salt water, which is inside the device at all times, goes back into the holding tank, right? And that's it. That's how it works. So that fluid that we put in there the first day of surgery stays in for 15, 20 years until the device breaks or until you break. So I'm going to go to the next slide here. 1 second. Here we go. All right. So whenever anybody talks to you about surgery, a responsible surgeon needs to talk to you about risks and benefits of a procedure. So I will briefly go into this. The benefits is that this works every time, and you don't have to worry about it not working. There's a lot of men who lose a lot of confidence, especially single men who are thinking about asking somebody out on a date. They never do it because they know that if it comes to the time where they want to have sex, it's not going to work, and so they don't engage anymore and they socially withdraw. So if you have this device in place or any other technique that's going to work for you, then you're more likely to kind of go back to a normal life and be a normal guy again. Easy to use. The sensation is not changed when you get this device, and it's covered by insurance. So interestingly, this solution for erectile dysfunction is the oldest one we have, invented in the 1970s. And pills and shots and all the other stuff that we have came afterward. Because of that, this is kind of grandfathered in to be paid for by Medicare. And so most people that have Medicare and a secondary insurance, this is free. Other times there's a copay. That's part of your insurance. But that's something we always check ahead of time if you decide to go through with this. What are the risks? The device can get infected. There can be mechanical failure of the device. People will always ask about if you can make the penis longer with the surgery. You cannot. If I could, I wouldn't have time to talk to you right now, because that'd be clearly making somebody's penis longer at the moment. So, yeah, the penis stays the same length. We used to think that maybe it gets a little bit smaller as a result of the surgery, but when we take good measurements, it stays the same size. But the penis does shrink, remind you, if it's not used for a while. So anytime there's disuse, then it can get a little bit shorter. And it also gets shorter if you have something called Peyronie disease, which Dr. Ziegelmann will talk about. And then another risk is injury to adjacent structures, urinary tube, etc. All in all, the satisfaction rate for these devices is anywhere between 90 and 95%. And then the guys who are dissatisfied either have unrealistic expectations, i.e. the device is going to make our penis longer or it's going to fix relationships. No, it's plumbing, right? We can make a good hydraulic reliable erection. We can't help beyond that, though. And then the other reason why people would be dissatisfied with the device rarely is if the device breaks. The device breaks seldom. At 5 years, 1% break. At 15 years, 30% break. At 10 years, about 15% break, right? So most guys, average age of implantation these days is about 65. Most guys will die with their device working, and only one device. So here's some more data. Again, this treatment is amazing. It works very, very well, high satisfaction, but only about 1% of men who are good candidates to get it. So you've taken a step in the right direction to learn about it. And if it's something you're interested in, we can schedule an appointment and get it set up. Surgery itself is pretty straightforward. It involves about a total operative time of 45 minutes to an hour, one night in the hospital, and then go home using the device in between 3 and 6 weeks after the surgery. We proved that putting in penile prostheses improves depression, not surprisingly. If you can fix this portion of a man's life, they get happier, as does the relationship. And similarly, for urinary leakage, there's a lot of guys that don't leave the house because they're afraid of having a urine smell in public or having an accident in public. These are things we can fix, and that's what we're here to talk to you about today. So that's my portion of the talk. This is these three people right here are the official Men's Health people. So I'm Dr. Kohler. This is Dr. Ziegelmann, who will speak to you next, and then Dr. Halo just started 2 days ago as our third fellowship-trained andrologist. There's no other program in the country that has 3 people dedicated to men's health. And then we also have a couple of world experts in fixing urinary leakage, Dr. Elliott and Dr. Viers, here to talk to you as well. We've got a lot of horsepower, a lot of team members ready to help take care of you and get you fixed if that's what you desire. So come see us. We will take questions about the various topics at the end, but that is all I have for now. And next I'd like to invite Dr. Ziegelmann up to give his portion. Thank you. Like double. He's trying to do it. I'm trying to do it at the same time.
Good evening. All right. Thank you so much for this opportunity to talk with you all tonight. My name is Matthew Ziegelmann. I'm, as Dr. Kohler mentioned, one of our men's health urologists specializing in sexual dysfunction. And tonight I'd like to talk to you for a few minutes about a couple of conditions that may be a little less common than erectile dysfunction or stress incontinence, but are still pretty prevalent in men who undergo prostate cancer treatment and can have a significant impact on your well-being. So the first is something called Peyronie's disease. And you may or may not have heard of Peyronie's disease. It's a wound healing disorder of the penis, and men present commonly with pain with erections. They note curvature of their erections, and that can be up, down, left, or right. They note shortening of the penis, and this can be in men who've had a prostatectomy or in men who have not had a prostatectomy. And a lot of times these men present with erectile dysfunction. Ultimately, all of these symptoms make it difficult to engage in satisfactory sexual intercourse. Now, Peyronie's disease is caused by a scar tissue that develops on the penis, and I like to explain this to patients as you think of the penis like a balloon. So if you fill up a balloon with air, that balloon gets wider and it gets longer. If we put a piece of tape on the balloon, and I have a little illustration here, that balloon is still going to get longer and wider, but the area where that tape is sitting can't expand as much. So you actually get more of a bratwurst shape to that balloon. We like food references in urology, so you may hear me reference that. But as you can imagine, seeing that change in the shape of the penis can be pretty disheartening for a lot of men. We hypothesize that this may be due to trauma, possibly because the erections aren't as strong, and there's probably a role of genetics in all of this too. But this is not very uncommon. We see that about 10% of men have signs or symptoms suggestive of Peyronie's disease. And we know that men who've been treated for prostate cancer have a higher incidence, probably on the order of 15 or 20%. Men who have diabetes, have issues with erections at baseline are also at increased risk. And oftentimes we see that men say, yeah, I have some scar tissue that develops in other areas of the body, such as the tendons in my hands. That's called Dupuytren's contracture, or sometimes trigger finger. The important thing is that this is widely variable in how men present, but we've got a lot of good options, and the first step is to come in and see us. So if we see a man and they have concerns suggestive of Peyronie's, we always start with a clinic visit, talking about your symptoms. Have you noticed curvature? Have you noticed shortening? How are your erections? We perform an exam, and then we talk about treatment options. And if men say, yeah, I'd like to consider treatments, the next step is to get a better idea of what you're seeing at home. So to do that, we do something called the penile ultrasound. And that's where we actually take pictures of the scar tissue. We can actually measure blood flow in and out of the penis, which is actually sometimes used to diagnose and treat erectile dysfunction. And then we actually can induce an erection to see, again, what you're seeing at home, because this helps us determine what treatment options are available. There are a variety of treatments, and I'll go into these in a little bit more detail. Some of this depends on how early you are in the symptom course. So if you present early, we may be talking about different treatments than if you present later. And again, I point out the food reference here. These are just a lot of interesting shaped vegetables. So oral medications, historically, these have been prescribed for about 100 years. There's been over 30 different medications that have been prescribed. Many of these have actually been debunked. They don't work. Vitamin E is definitely the most common medication prescribed, and there's good data that says that doesn't work. But some of the other meds may work. We just don't have a lot of strong studies. So many experts, including myself, will consider using oral medications in conjunction with other treatments. One of the most common medications I prescribe is a medication called Cialis, or Viagra is another option. These medications help with erections, but they also may help with some of the scarring that occurs on the penis. Now, I think this is a very important treatment for many men. It's called penile traction, and this may be relevant to some men even who do not have Peyronie's. So penile traction is using a device, and the device that I commonly recommend is one called Restorex. It was actually developed here at Mayo Clinic. It looks like a little bit of an intimidating contraption, almost like a spaceship, but it's actually pretty easy to use. And you place the penis in this device, it puts gentle stretch on the penis, and this is the only treatment that's been shown to improve penile length. So, even I'm here with you tonight, and I have a treatment that can potentially improve length. But it's a great option for a lot of men, whether you have Peyronie's, We are seeing improvements in penile length for men who have had prostatectomy and don't have evidence of Peyronies, because this can be really bothersome for a lot of men. But in Peyronies, we're also seeing improvements in penile curvature and penile girth. And this is a really well tolerated, once you get the hang of how to use this medication, there's minimal, or this device, there's minimal side effects. In men who have more prominent curvature, sometimes we'll actually inject the penis with medications to try to break that scar tissue up. The agent we use most commonly is known as Xiaflex. It's the only FDA-approved medication for Peyronies. And this is covered by the vast majority of insurance companies, and it does improve penile curvature in the majority of men. And it also decreases the bother associated with this type of process. And then for men who have more significant curvature and are significantly bothered, we do have surgery as an option. So in men who have good, strong erections, we can straighten the penis by putting sutures in on the area opposite where the curvature is to try to pull that penis straight. We can sometimes incise the scar tissue and then put a piece of tissue over that by sewing it in to help straighten the penis. And in men who have erectile dysfunction and curvature, which I mentioned is really common, we can do a penile prosthesis like Dr. Kohler mentioned, and then do some additional maneuvers to help make sure the penis is straight and you're able to engage in satisfactory penetrative sex, which is the goal for these procedures. So I'm going to switch gears a little bit and talk about one other condition that's quite common after prostate cancer surgery and prostate cancer treatment in general, and that's something called climacturia. So essentially what this means is bothersome leakage during sexual activity, and that can be during the act of intercourse or with climax. And this is pretty darn common. Some studies have suggested that up to 60% of men who undergo prostate cancer treatment, whether that's surgery, radiation, or definitely the combination of both, that these men may have bothersome climacturia. And this is even present in men who don't leak during the day. So men who are dry and don't wear pads are still bothered by this. And it's not only bothersome for the man, but it's also bothersome for his partner. But this is something that's really challenging to talk about and often not brought up with especially the prostate cancer surgeon. You know, we're so excited about the fact that our prostate cancer is under good control. But let's talk in a little bit more detail about, the side effects. Sometimes that can be a little bit challenging to bring up with your surgeon. We do have excellent treatment options for climacturia as well. Some easy options are we encourage men to empty their bladder before engaging in sexual activity. We can work on strengthening those pelvic floor muscles. I'm sure you all remember the good old Kegel exercises to help that sphincter before and after surgery to try to preserve continence. Men can sometimes use constriction bands at the base of the penis to try to prevent that leakage. But some men are bothered enough by this that they want to consider surgery, and we have good options. My colleague, Dr. Viers, will be speaking with you shortly about a male urethral sling to help with incontinence, daytime leakage, and this is a good option for bothersome leakage during sexual intercourse as well. And then in men who have erectile dysfunction and a leak, in addition to placing the prosthesis, sometimes we can place a sling material to help support that urethra and minimize the bother with the leakage. So thanks again for this opportunity, and I just want to reiterate what Dr. Kohler said. We've got a team of experts here, a lot of good experience, and we can help whatever issue you're dealing with. We've gotten you over that hump of beating the prostate cancer, and now we want to be here to help you live a better quality of life. We just need to see you to determine what options we have available for you. And with that, I thank you for your time, and I'll ask Dr. Viers to come up next.
Howdy. Well, we just broke the ice there, didn't we? It's nice to have the men's health team, Dr. Kohler and Dr. Ziegelmann, talk about erectile function and kind of that part of things. And it makes my life easier. I'm one of the reconstructive surgeons here, so I deal mostly with the urethra, and that's the tube that men urinate out of from the bladder to the tip of the penis. And part of what comes with that is urinary leakage. So Dr. Kohler showed you a slide at the beginning of the talk, and it kind of showed you the real estate in the male pelvis, and a lot of that can be impacted after prostate cancer therapy. You have the prostate, you have the urinary sphincter muscle, which controls the ability to stop your urine or to keep from leaking. You have erectile function, you have the rectum there, you have the urethra there, and all these things are intertwined. And so while erectile function may be one part of it, you also got to think about the urinary leakage and how that plays into it, and even scarring in the urethra. Does this resonate with anybody? So similar to erectile function, male stress incontinence after prostate cancer therapy can occur in up to 3 out of 4 men, and it can be bothersome enough that they need to seek treatment. It doesn't have to be like this. So this goes back to the anatomy lesson 101. So this is a cross-sectional image of the male pelvis, and the arrows you see there are defining where the urinary sphincter is. So when you have a prostatectomy, here sits your bladder. That's the pubic bone or the bone in front of the bladder. There's the prostate. So they remove the prostate, and then they connect the bladder back to the urethra. And what controls your urine after this surgery or after you have radiation a lot of times is this muscle right here. That's called the external urinary sphincter. That's the voluntary muscle. That's the muscle that you use if somebody walks in on you unexpectedly in the bathroom and you need to stop your stream midstream. The external sphincter. Does anybody know who this is? Okay, all right, well. So this is Mr. Olympia. And you may say, well, why am I putting up Mr. Olympia when we're talking about male incontinence? Think of it like a normal male sphincter. And this is an image when you drive a scope through the urethra and you're looking at the sphincter. And you're asking a man to activate that sphincter. So equate that to somebody who has normal sphincter function, and it's a strong, healthy, robust muscle. What about this guy? What do you think his sphincter is going to look like? There you go. So what you see here is you see that pinpoint opening. And while that may not be that big of an opening, it just takes a little bit of sphincter insufficiency for you to have significant urinary leakage. And so this is what a man who's had a prostatectomy, maybe had radiation, may look like. And so you got to find a way to regain that urinary control. So we can all high five as urologists, right? So we can say to a man who has prostate cancer treatment that most of you will regain your urinary control by 1 year, and about 10% of you will have bothersome leakage after that. But that's not the case, because over time after a prostatectomy or even radiation, the urine leakage can worsen. And a lot of that is due to physiological factors or changes in your muscle mass, or the fact that as you age, you're more likely to have bothersome urinary leakage. And so if you look there at 15 years, even up to 15% of men have significant urinary incontinence that they need treatment here. So what are our options? Well, for male incontinence that's related to prostate cancer therapy, medications don't work. We use those in other forms of incontinence, but not for stress incontinence in men. Injectable bulking agents, where we go in with a scope and we inject some bulking agent or some gel around the urethra, doesn't work either. And we also know that there's other types of treatments, such as neuromodulation, that don't work. What does control the urine? Well, we all know about a urinary catheter, but who really wants to live the rest of your life with an indwelling catheter? You also have a condom catheter that's more like an outside sheath that catches the urine that leaks from the penis as well. Those are options for some men. You have compression of the urethra. We have a Cunningham clamp is what we call it, and it's a device that squeezes down the urethra so that you won't leak out the tip of the penis. There's also a male acticuff which acts like a clamp, but then it catches the urine in almost like a receptacle to keep it from soiling your underwear. What about physical training? So you saw Phil Heath, this Mr. Olympian. Do we have any evidence that if you do pelvic floor muscle training, that this is going to improve your urinary control, similar to lifting weights? And the data would suggest that it helps you get early return of urinary control up to 1 year after your prostate's removed. But after that, the data is kind of iffy, because over time, that sphincter may weaken. And so we don't really know what happens if you're to start this muscle training, say 3 or 4 years down the road, but data would suggest that it's probably not going to help at that point if you have significant leakage. We do pelvic floor muscle training on Gonda 7 in our department. We have almost a streamlined pathway for men who come back after they have prostate surgery and have their prostate removed, where they have an evaluation. If they have bothersome leakage, we send them through this biofeedback where you actually can see when your pelvic floor is contracting and not. And then you can try to activate those muscles. And this is actually the room up on Gonda 7. And so they place these little electrodes which can measure some of the impulses in the muscle in your pelvic floor to help you do that. And here you can see a patient when our pelvic floor physical therapist asks them to activate their pelvic floor. That's when you see the contraction and then the relaxation and the contraction, so it can teach you how to do that. But let's not be naive. For most men, though, that isn't the answer for significant leakage. So don't put your head in the sand and just say, well, I got to live like this. And what we see is that lots of times men are obviously happy if they're not wearing any pads per day, but even at 1 pad a day, that is a significant burden on a man, and it leads to significant changes in their lifestyle to the point that it actually can become quite detrimental. We found that actually most men don't seek treatment for their urinary incontinence after prostate cancer therapy for up to 7 years. So you're all raising your hands. Congratulations on coming, but I did see some hands go up from patients who've had their prostate surgery or radiation 10 years ago, almost 10 years ago, right? So good, I'm glad you came. Let's talk about what does work. So there's 2 flavors when it comes to urinary incontinence treatment after prostate cancer. The first is a sling. A sling is made of a synthetic mesh. It doesn't have any of the fluid components, and it's for mild incontinence, okay? The other is a sphincter, which Dr. Elliott will talk about. So how do we decide who is a candidate for what? And basically it comes down to several factors, and it's very simple. If you cough and you don't leak when you have a relatively full bladder, or like when Dr. Ziegelmann talked about climacteria alone, that's a patient that's a sling patient. If you cough and have a few dribbles, or you wear less than 2 pads a day, and you haven't had a radiation, you're a sling patient. If you're anything more than that, meaning anything that's moderate to severe incontinence, you're an artificial sphincter patient. And so this kind of goes through how we do that. So you come into my office, first thing I'm going to have you do is drop your pants. We do a handshake, and then I say, okay, let's see what your incontinence level is, right? And I have you cough in front of me, and then we can grade it. And that's how we say you're a sphincter or you're a sling. And so here's a male sling. So the way that we do a male sling is you make a small incision below the scrotum, and you make 2 very, very small incisions in each groin. We dissect down to the urethra. You place the sling underneath the urethra like a hammock, and then you tension it. And essentially what it does is it repositions the urethra and essentially reinforces your existing urinary sphincter. So you still have to have that sphincter function to get a male sling. I know there's been a lot of data that's bad press about mesh. That does not apply to this device. Okay, that applies to pelvic organ prolapse surgery or surgery in women who have mesh. So completely different, so we can take that off the table. So this is a picture of us scoping a gentleman who's having this sling placed. And what we're looking for is a repositioning of the sling. So essentially I'm tensioning that up while he's asleep on the table. So this is before, and you can see here, this is going into the urethra. This is during. You can start to see how the urethra is starting to collapse on itself. And this is after. You can see that the urethra is completely compressing, and so I couldn't drive the scope through. That's what we want to see. And that's how it works. It's reinforcing what you have. So again, to stress the importance of patient selection with this. The number one problem with placing the sling is placing it in the wrong patient. If you place it in the right patient, that is, they have to wear 2 pads or less a day. They have to have, when we do the standing cough test in the clinic, it has to be the lower grade. And you can't, and there's no radiation. If you've had radiation, we're talking a sphincter. If you meet all those criteria, the success rate is about 85%. And that means that If you're at less than 2 pads a day or 2 pads a day, we're going to get you to less than 1 pad a day or a safety pad. And if we can do that, most men are pretty darn happy. Other things that can affect the quality of life with the sling. Another one that is mentioned is sometimes in less than 5% of men, they do get some groin pain, but that's usually transient and goes away over time. The nice thing about this device is that unlike the sphincter and the penile prosthesis, it doesn't involve fluid, so it's less likely to break or to need to be replaced. Now, the one caveat there is the sling in the Minn we don't have long-term data beyond 5 years, so I don't know if, say, 5 to 10 years down the road, we place a sling, you're dry. There is a small chance that over time your incontinence can progress and you may need more treatment. So we don't know exactly really long-term results with it, but in the 5 to 10 year range, it is successful in the patient we mentioned. Okay. So now we will talk about the sphincter, or the artificial urinary sphincter. Thank you.
All right, well, last year when we had this in November, there was a huge snowstorm, and our attendance was a little bit on the sparse side, so we're kind of nice. So we thought this through and said, perhaps in Minnesota, we should not do this in the winter. This is me. I'm also in the section of pelvic and reconstructive surgery. And what you've heard tonight, the amount of information has been obviously quite a bit. But the important take-home message is you heard from 3 highly trained experts about this. And unfortunately, in men's health, and what I mean by men's health, the reconstructive, the picking up the pieces after prostate cancer. And I joke facetiously that I'm the janitor. I'm picking up the messes after the prostate cancer surgeons and radiation have done their thing. And interestingly, we did a study on the men who've had radiation who come to see me, and 8.5 years after radiation is when they start seeing me, because the effects of radiation continue forever. That's why we're joking. We're picking up after the prostate cancer has been treated. The men are now cancer-free or the cancer controlled, and now we're left with problems as a result of the cancer treatment. So, hearing the individuals tonight, remember a lot of times, if you can remember this stuff, that unfortunately, if you're not seeing an expert, a high-volume expert, the decision-making of what you get, whether it be a penile prosthetic versus injection therapy versus for the incontinence, a sling versus a sphincter, are significant. I personally do not do slings. We have Dr. Viers do them, but I have taken out a lot of slings because they were poor patient selection. And ultimately, the person who suffers is the man, the patient, and then his family. And we have data from here, and there's also been reproduced data from Netherlands that men who have slings put in and then go on to needing a sphincter, artificial sphincter, the sphincter does not work as well. There's higher complications. So that's why it's very important when you go see your physician, find out the volume that they do. And I can speak for artificial urinary sphincters. If that doctor does not do at least 20, the data is very clear that their skill levels and their complications are going to be about double or triple people who do above that number. So always ask. Then you may ask, well, what does the average urologist who do artificial sphincters, how many do they do in a year? Does anyone have an estimate? Just throw out a number, any number. Somebody be bold. 300. 1. In the United States, the average urologist who treats male incontinence does 1 artificial sphincter a year. In the United States, there are only 5 who do 20 a year. The data also shows that you have to do at least 200 to be an expert, where you start seeing the complication levels plateau. And so that's where it's imperative for you to be searching for a high-quality, large-volume surgeon and be bold and ask, how many of these do you do? If the answer is, oh, a lot, how many is a lot? This is your body. You will suffer the consequences. 20% of my practice, is fixing artificial sphincters that have been ruined somewhere else. So again, and then who suffers long term? It's you. So just be careful. A lot of times, I'm from LA. Now that's not necessarily a good thing. We joke, underneath the glitter is more glitter in LA, the people. Midwesterners are nice people. If I ever have a car breakdown, I want to have it in the Midwest, not in LA. In LA, they'll just drive by and shoot you, and that's it. And that's unfortunately not a joke, it happens. In Midwest, they'll stop and help you out. But Midwesterners also, as far as they're too nice sometimes with their doctors and just believe. Trust is a good thing, but back it up with facts. And so just ask questions and things. So, with that said, we've already talked about this, okay? And it's very important. Every single patient comes in to see me. Now, Dr. Viers said the first thing that he does is have the patient drop their pants. I don't. Okay? We wait a little while, then they drop their pants. Okay? So it's a little different approach, how we deal things. But these options are always discussed. Rarely, when I see a gentleman, essentially, I do about 100 to 115 artificial sphincters a year. And 3 or 4 a year have leakage that's light, and that goes to then I send them over to Dr. Viers because he is the expert in dealing with that. Bulking agents, that's where you kind of tighten up the sphincter. It sounds brilliant. Oh, you just do a little injection in the office, and it tightens it up, and it'll work great. Okay, that falls in the category of bull. Okay, it doesn't work. The Ed McGuire, who was the first person to write a paper on this. Well, he's retired now, but he stopped doing it in 1996. Okay? It still gets done a lot. Usually it does no harm, but 15% of the time it can make the incontinence worse. Again, if somebody's recommending that, run. Just say thank you very much and then run. Kegel exercises, I won't get into those, but this is Dr. Viers' talk. Okay, so now the artificial sphincter. Simple device, brilliantly simple device. Came out in 1972, and Dr. Brantley Scott at Baylor invented this. And then he promptly got a lot of money for it and built his own airplane and crashed it and died. Then Mayo, being in the backyard of a company up in Minneapolis, took the ball and ran with it and has the world's largest experience by far dealing with this. And if you look at this drawing, if you go down here, you probably can't see, this is a Mayo Clinic drawing, 1983. The 1983 model and now is identical. Hasn't changed at all, which I always tell the company is embarrassing. The company's not trying to work and get it better. But it still is the same principle. Now we're working with a company in Paris who has a new design that it will be much more improved than this, but it has to go through FDA trials, which we're doing here next year and things like that. But right now, this is it. 3 simple little components to it. And you can be naked as a jaybird, run around. I saw somebody with the Packers game or whatever. You can be run around Lambeau Field, buck naked. No one can see this at all. Okay, something to plan on someday after a few beers and things like that. You wouldn't do it at a Vikings game because they're always losing. You'd just be depressed. At least the Packers have a chance of winning. There's a low pressure reservoir. Little, about not even the size of a golf ball, and that's kind of the engine. There's a little pressure in there that drives the fluid back down here. There's a little cuff that goes around the urethra like a blood pressure cuff, just around the urethra like this. You cannot feel it at all, but it's closed. It's tight. And then there's a little pump that's in the scrotum. This is the actual size of the pump, so we're not talking big at all. And the way this thing works is when the man gets the desire to go to the bathroom, he goes in the bathroom, he drops his drawers, and presses this pump, usually once, maybe twice, to get it working. So I tell everybody that in order for you to, if you're a sphincter candidate, you have to have leakage, usually the 2 to 3 pads and up, and have radiation, etc., or plus or minus radiation. But in order to work the sphincter, all you have to be able to do is to do this. It's not difficult at all. But men have to be able to remember how to do this. So mentation is important. I talk to everybody when they come in the office, and I've done now 1,605 of these procedures, so I have a little bit of practice at it. But talking with a man, you can almost instantly tell if there's going to be an issue with mentation. If I ask a question and the wife immediately talks, it's a warning sign. that there could be a relationship problem, or she's learned to compensate for the man. And so I say, because he's having trouble remembering things. And so then I say, well, let me just hear from him right now. And if she gets mad, then there could be something else going on, or she is upset because she's learned he's having trouble. So anytime I perceive issues where the man has problem with mentations, artificial sphincter probably could be out, because again, he has to remember how to do this. It's not difficult, but you've got to do that. Now, the way this thing works, as I mentioned here, press the pump, cuff opens up, you urinate. And automatically, over a period of about a minute, it closes, because the pressure in the reservoir drives the fluid back down to the pump and into the cuff, and it closes. It's brilliant. And that's probably one of the reasons why in the past, what is it now, 48 years or whatever it's been, there has not been an advancement in this. So again, it's just a simple little brilliant device. Now, this is our series at Mayo. This is just about 1,000 of our cases here. And again, to give you the idea of the size of this, these are the first-time implants. The next biggest institution is Duke, who has about 200. So it's a common thing. And I got trained by two of the world's experts. So I got to have the advantage of learning from their experience of doing thousands. But over time, as Dr. Viers mentioned, this can wear out. And I tell everybody, it's just like if you go in and get a brand new car at GM, Chevy, or wherever, over time the fuel pump will break. Well, with this, it can wear out as well. And if you look at 10 years, right here, that's roughly 50% of sphincters are in doing fine. 50% have had to be revised. If you look at the total number of men who have a sphincter still in place with it being revised, analogous to a car on the road that's 10 years out and has had to go into the shop a couple times, 96% of the sphincters put in at Mayo, 96% of the men who had sphincters put in at Mayo at 10 years still have a sphincter in and it's working. Okay, so the long-term success with it is very good, but it does wear out. Okay, now, who is not a candidate for a sphincter? This is where the judgment comes in. As I mentioned, light leakage, Dr. Viers mentioned, poor hand function. Very, very rarely is this an issue. Now, I had an old World War II vet that the last week of the war in Germany, a German, tossed in a grenade, and he blew off these fingers, and then he only had, I think, a thumb and a small finger here, and he was able to work the sphincter. But there's other conditions, bad rheumatoid arthritis, those types of things, where they cannot work it. It's pretty rare for that to be an issue, but that can be an issue. Decreased mentations we talked about. Now, ultimately, like Dr. Kohler mentioned as far as the penile prosthetic, if there's one thing in urology that makes men happy, again, I get men who are coming in who are leaking heavily, like from the 2 to 3 pads up to total incontinence, total urinary incontinence, 2 liters of urine, like one of those big bottles of Pepsi leaking out every day. We put the sphincter in, which is a small surgery, roughly 45 minutes worth, and they are ecstatic. I tell everybody, I cannot guarantee you getting completely dry. I'll give you, and this is Mayo Clinic data, Mayo Clinic Rochester, I'll give you a 75% chance of completely dry, 25% chance of needing to wear 1 pad a day. The men who come in who are down from leaking all their urine out or close to it to 1 pad a day are thrilled. Okay? And then if and when it wears out over time, they come back and say, fix this, I got to get back to the way I was.